Welcome. Thank you all for coming to our update on injectable PrEP. I'm Robert Wilder-Blue with the California Prevention Training Center. My colleagues here today from the Prevention Training Center are Liz Chow, our fabulous producer. It's always good to be able to use the word fabulous at least once. And Tamara Ooms, who manages our CompC and A1 technical assistance programs. So I want to get right down to it because we have a lot to present today. Liz, could I share my screen briefly? Some of you, I believe, have already seen this, but I wanted to give you a quick tour of our long-acting injectable PrEP website. As you can see, we have clinical frequently asked questions in English and Spanish. We have access and financing, frequently asked questions in English and Spanish. I'll just pop into this to give you a little bit of a look at what this is. When you click on the question, it gives you, I was going to say a brief answer. This looks pretty long, but at any rate, it gives you a succinct answer. And then it usually has a link for more information. I will say that probably about half of this information is relevant only to California because of our specific California Medicaid, and because of our PrEP assistance program here. But I think some of the access questions are also relevant to every state. And then finally, we've started to get together a library of different resources. I want to highlight the National Clinical Consultation Center, which has been around for quite a while, giving clinical advice on PEP and PrEP, and now on injectable PrEP. We have the recordings from our previous sessions. And then we have, there were some programs that were kind enough to share their protocols and some of their other procedural documents with us. So if you have any questions about that, feel free to either email me or type them into the chat. I'll stop sharing my screen now. And let's get right to our updates. Our first presenter is Jillian Narcisse from the University of Miami Miller School of Medicine.
Hello, good afternoon, everybody. My name is Jillian. I'm a clinical pharmacist here of Miami, and I'm going to share some updates since we last saw each other back in April about our PrEP program for Aptitude. Just a quick background about our program. So we first started as a mobile clinic providing PrEP in different areas of need in South Florida, Miami area. And we have since then expanded to clinics, and we also expanded onto a clinic within a Walgreens, so we can have like direct, they can get their medication right away after seeing the provider. So it's just a quick background about our program. About our demographics, we have started about 1,500 patients. We've seen them in about 864 PrEP starts, with the majority of them being Hispanic Latinx patients. And the average age is about 36 years. So when we first met back in April, we had three, because we're still testing the waters for the injectable PrEP. So we had only like 3 patients that we were trying to figure out how to develop a protocol on Aptitude. So since then, we now have 15 patients, and about 10 are Hispanic Latino, 3 are Black, and 1 is female of them, and 2 are white. And in this time process, so we have tried to figure out the timeline to starting it. So for the uninsured, it's about 2 weeks from when they are seen to receiving the injection, because it's very quick. But for the insured patients, it varies like about from 1 to 3 months. And right now we have 8 patients who are uninsured, who are on the Amplitude, and about 7 patients that are insured. And in trying to figure out the process, we shifted from a virtual model to an in-person model where we do everything in person at the clinic. And that is mainly because we're having a hard time, reaching out to patients, and just like delays. And at first, we started more as a self-referral. So we spoke to the patients about it, and they we put an interest list. And we had about 66 patients in that list in about 3 months. However, in streamlining the process, we realized that some of the patients would not come for their visits. They would come whenever, and like the window is very small. It's 7 days before or after for the injection. So we reviewed our procedures, and so we developed a new plan, and we have now a pre-assessment, and we are more stringent in the screening for the injectable, and only selective patients at this time will start this medication. And also they have to sign an agreement form. And also we have now a cap of how many people we can take a month until we can take on more patients for the injectable. And also with that being said, with the insured patients, I really utilize the Vive Connect portal with the they have like a secure messaging system where like, so the insured patients are really very challenging. So like with the insurances and the pharmacy, like it's a lot back and forth essentially. So I really utilize this as my tool for the insured patients, because that is the biggest challenge that I think we've faced so far, and as well as like compliance with the patients. But that's about my update, and I'll answer any more questions you guys may have later on.
Great. Thank you so much, Jillian. Our next presenter is Luis Felix, who's manager of HIV prevention and linkage health services at the Los Angeles LGBT Center. And I think, Luis, you're going to tell us about your pilot program.
Hi, everyone. Thanks for organizing this, Robert. I was hoping I would be towards the last, but here I am. We're also rolling out a pilot program. We initially created 5 slots for 5 clients, but just to understand how the flow would be clinically and also for the patient at the center. But pretty fast, the providers were asking me to add more patients if we could. So at this point, we are accepting 10. I have 7 fully enrolled. One of them already did 3 shots, so they have their 4th shot coming up in December. And then three of them are about to get their 3rd shot, and a couple are going to start soon. Only one is going to do the oral lead-in. We have a variety. Of course, the majority of people are cis males, and then we have sort of 50% are Latino identified. I have one cis male who's African American, a trans woman, and a non-binary client also. So pretty diverse for such a small group. So basically, we initially started by just accepting clients who had Medi-Cal. Because that just made things so much easier. We know that Medi-Cal fully covers this medication. We also have a pharmacy on site on the 1st floor, so that has simplified a lot. Since it's a pharmacy benefit, we basically have the clients come in 15 minutes prior to their appointment, go to the pharmacy, pick up their medication, bring it up, and then check in for the appointment. They will see the provider briefly, do labs if they have to, and then have the nurse administer the injection. It sounds a little weird at times that the client picks up the medication and brings it up to the third floor. Because they're not supposed to leave the center with the medication, right? So it creates that kind of window, but for the most part, it has been working. I have not rolled out this to my staff, to the PrEP navigators, so I am personally handling all the scheduling. For the oral PrEP, we do a lot of retention strategies. The biggest one is a reminder that we send to clients based on, we just run a report every day based on prescription dates when they're supposed to be running out of medication, and we send an email or a text message saying, hey, it looks like it's time for your PrEP follow-up. They can actually self-schedule through a link, or they can call the PrEP hotline and call themselves. So before I roll out to have my staff handling the scheduling, I'm trying to create tools that would work in the same way for the injectable, since the timelines are a little more initially maybe more complicated to navigate. So my HIS department is working on creating a report that will have intelligence and logic behind to know the difference between the first and the second and the third shot, so that I can easily pull a report and then automatically send those reminders to the clients. I feel a little bit nervous about the timeline for clients to remember to come in and get their shot in time, so that we don't have to go back to the oral. But I'm noticing that's my personal anxiety of just wanting this to work for our clients. And we do serve a very disenfranchised population who has at times really difficulty in adhering to medication. And since this is a little more strict, I want to make sure before I roll out, I have some tools in place to support with retention. We have a representative for ViiV coming in today, actually, to teach or train me and my enrollment worker with just more detail on the patient assistance programs from ViiV. And then I will train my other staff just to have that knowledge, because at any point, any of my PrEP navigators should be able to submit a PAP or assist a client enrolling into the patient assistance program. So like I said, initially, we were just working with clients who had Medi-Cal. Now I'm including others just to try that out, how it is for us. I know that with a simple phone call or email, we can have ViiV check the insurance coverage for us. But since I have a pharmacy, I basically just message the pharmacy, and they can run a test claim based on the insurance we have on file, and see what comes back, what kind of copay, if any, at all. So right now we're waiting on, we had to submit a PA for a client who has private insurance and Medi-Cal. So we submitted a PA to see if their main insurance, the primary insurance, would cover, and we're just waiting for them to get back on that. And today, so we're focusing all this in one provider, in one location where we have the pharmacy. We have other locations that don't have a pharmacy, have a dispensary. So we have to work out to see how it's going to work out in those locations. But today, another provider is joining. So I'm going to have two providers with whom I can schedule the clients. One operational difficulty in the beginning was that normally we only open our schedules 1 month ahead. And this is based in very complex calculations about no-show rates, right? The further out we book clients, the higher is the no-show rate. So that was the sweet spot around 30 days. Of course, with injectable, that didn't seem quite to fit together. We want the clients to leave the center and have their next injection scheduled, right? So we had to kind of rearrange and reconsider our policy. So now the schedules are open 2 months in advance, so that on average, everyone can get their next injection booked. And when they can't, as soon as the schedule opens, I reach out and
Louise, I just want to give you a heads up. You have about a minute left because we have a jam-packed agenda today.
Yes, thanks for that. Yeah, I just wanted to end with that. Being able to schedule clients for the next appointment when they're here it's a great benefit. I'm glad we were able to make that work. Thank you.
Great. Thanks so much, Luis. And I think we'll put, what's the saying? We'll put a pin in this one question to follow up about accessing the medication through Medicaid in California, Medi-Cal, and also how that is covered as far as the Medicaid insurance goes. Caroline Sacco, do you feel like going next? Caroline is from the Baltimore City Health Department, and she was also with us a few months back, and she's going to give us an update about how things are going there.
Thank you, Robert. Thanks, Liz. Hi, everyone. So I'm from Baltimore City Health Department. We're a small city health department with 2 sexual health clinics. And we started our pilot for Apretude injectable PrEP in February. Our first patient got his injection in April. And now we have 11 patients on Apretude. 9 of those patients were transitioned from oral PrEP, and 2 of those patients were one other patient was on NPEP before transitioning to injectable, and the last patient was actually doing PrEP on demand and decided that he would prefer to have something more steady because he was having trouble anticipating and predicting his sexual encounters. So we have patients that range from 24 years old to 42 years old. We have 7 people who are African American or African, 1 person who's Latinx, and 3 people who are white. In preparing for today, Robert asked a good question about our insurance coverage, and I realized that most people who are on PrEP, injectable PrEP with us right now are uninsured. And I think that that's definitely related to, how easy it is to get somebody on if they're uninsured versus filling out a prior authorization with their insurance company if they do have insurance. So we have, let's see, 2 people who are on Medicaid, 4 people who have private insurance, and everyone else is uninsured. I've noticed that in terms of the flow from talking about injectable PrEP to actually getting the first injection for somebody who's uninsured, I think 2 weeks or even, between 7 days and 2 weeks, 1 and 2 weeks is usually our range. And I've had a couple of instances where I've actually been able to have a conversation and do some education and get someone's RNA at one visit, and then within those 7 days have the medication actually delivered to our clinic. If they're uninsured, it can be sometimes really quick, which is great. For somebody who has private insurance, it can really range, private insurance or Medicaid. It can, the time to first injection can vary based on how much bandwidth I have to do paperwork. Similar to Luis, I'm also sort of a one-woman show right now. So if I have a lot of time and can do the paperwork swiftly, people who are on private insurance can get their first injection as soon as 2 weeks if we hear an okay from their insurance company. It could be longer than that if we get a denial, which we've only had one of, or if I'm just inundated with other clinic tasks. In terms of recruiting patients, and this kind of touches on keeping an eye on our equity for this rollout, we initially were allowing people to come to us, and it lined up perfectly, our rollout, with a survey that we had released that talked about injectable PrEP. So a lot of people, we sent the survey to everyone. So everyone who completed the survey, a lot of them actually came to us and said, I want to be on injectable PrEP. So those were kind of like people who self-selected, who were early adopters and very interested. But, those aren't necessarily the people who would really, really benefit from being on injectable PrEP. So what we're trying to focus on now is mentioning it, just doing some education around injectable PrEP for everybody, whether they're on PrEP, oral PrEP with us or not, just so that everybody has the decision, the information to make a decision for themselves that's best. So that's one thing that we're keeping in mind. Um, so the person who started injectable PrEP with us back in February is on his 5th injection, and we have some people who got their first injection last week. So that's kind of our range and where people are in their injection. Back to demographics really quickly. We have 9 cis men, 1 non-binary person, and 1 cis woman. And in terms of retention, because in the beginning people were sort of self-selected, we haven't had issues with people not showing back up for their appointments. It's actually been, people are really eager. And so I am personally calling people back to remind them for their appointment, which is something I don't normally do for people who are just on oral PrEP. Usually our patient navigator does that, but for now, right now in this phase, I'm actually calling. Let's see. One pleasant surprise has been, like I said, we've only had 1 denial in our PAs, so that's been a pleasant surprise. Unfortunately, here in Maryland, we don't have, Medicaid has not approved this across the board. It's still plan by plan, but I've been pleasantly surprised that we haven't had to go through too many hurdles so far. So, yeah, that's my update. Thank you.
Wonderful. Thanks so much, Caroline. And now our 4th presenters are Ben Lomelli and Paul Lovely from St. Mary Dignity Health Center in Long Beach, California.
Hey everyone, and Christine is on too, I think. And
good.
yeah, thank you so much. Good to be back here with you, Robert, and everyone, and to see check on everyone's progress. I'm going to really defer to Ben and to Christine, and they're the ones in the front line, and they've been doing a lot of good work with our injectable program. So I'll turn it over to them.
Yeah. Hi. Hello, everyone. My name is Benjamin, but I go by Ben. I'm the Biomedical Prevention Services Coordinator here at Dignity Health. I'm 3 months in my role, so I'm relatively new. But I'm going to go ahead and just present on sort of the breakdown, demographics, how many patients we have, all of that. And Christine can sort of elaborate on sort of our workflow and where the bulk of our patients come from. So we actually have 38 patients who have received at least their first injection. 7 of those 38 patients have received at least 5 injections. Our patients are overwhelmingly Latinx. So 79% or 30 of those 38 patients are Latinx. 2 of those 38 patients are Asian, 3 of those 38 are white, and 3 of those 38 are Black. We have 37 male, 1 female, 2 bisexual, 1 straight, and 35 gay. Let's see, 50% of those patients are enrolled into the ViiV Patient Assistance Program. 13 or 34% are in Medi-Cal or California Medicaid. And 6 of those 38 are enrolled into some sort of private insurance. So I've really been helping patients navigate right now through the whole private insurance. That is definitely a challenge. As some of the speakers have mentioned, most private insurances will require a prior authorization. So I've been working hard on getting that process started. We've only had 1 prior authorization that's been denied, but we were given the option to either appeal or have Christine sit in peer-to-peer with the medical director of that insurance company. So Christine actually talked to the medical director of, I believe it was United Healthcare, and it got approved after that conversation that they had. So we're getting that patient started on Apertude. We actually have 2 patients scheduled tomorrow, so that'll put us at 40 patients on Apertude. The bulk of our patients, I believe, are existing PrEP patients who are on oral medication and have transitioned onto injectable PrEP. Christine, I'm not sure if you'd like to elaborate or touch upon anything that I may have missed.
The only thing that I did want to say is that, yeah, some of the insurance companies want to know which 3 medications they have failed before they approve this, which, as you know, is sort of an impossible thing to come up with. But in this particular case where they did approve it, we do something, well, in addition, I focused on, when we were on the phone, on the patient's recent sexual history, where they said that they had 10 partners in the last 3 months, and that they were all, he met them all on social media. And that seemed to kind of push the the insurance person, okay, this guy's at risk, if he wants injectable, that sounds like a good idea. But that might be something that you might investigate when you are on the phone, if you are doing an appeal. Let's see. Yeah, other than that, yeah, I know you have more statistics. I don't know if you want to go with a little bit more of your evaluation, and then if there's anything to say from there.
Yeah, so I guess one recommendation for any PrEP navigators out there, I've been relying heavily on ViV's field reimbursement managers. Monica Solis has a pretty big swath of Los Angeles County, and she's been coming and meeting with me every week, and she's really been helping me navigate the private insurances. So you can contact ViV Connect to locate your local field reimbursement manager, and they're a great resource. I think in terms of timeline for patients who are enrolled into the patient assistance program, it takes about 1 to 2 weeks for them to get started on the medication. Same with California Medicaid, about 1 to 2 weeks. But again, with patients who have private insurance, it can take anywhere from 2 to 4 weeks, if not longer, just getting the PA submitted and waiting to hear back from the insurance company. So that's definitely a barrier. But yeah, I don't think we have, or I don't have anything else to sort of share.
Yeah, if there's any questions, we could certainly ask though.
Great. Thank you very much. So the first question I want to ask, which a couple of people have asked me in the past week, and I haven't known the answer to, is for people with Medicaid, what are the logistics for getting the medication to the clinic or to the provider? And I'll divide it, I guess, into two portions of that, or 2 topics, which is, I know we have a lot of people from California on the call, and so California's Medicaid is Medi-Cal. So I wonder if any of the California folks could walk us through how you're getting the medication for Medi-Cal patients.
Sure. Okay. If a Medi-Cal patient states that they do want to go on Apertude, the first thing I need to do is put in a request for an auth for the injection. Okay. And that usually takes about 2 weeks. So I immediately put the auth in because all the Medi-Cal plans need an auth for the injection itself. We have a pharmacy right next door, and Medi-Cal does cover distribution of that medication from there. So then once we get the auth, I just send them a prescription and go pick it up. They keep 4 on hand at all times, just in anticipation of us needing some.
That's great. Anybody else have anything to add to the Medi-Cal procedures?
I'm just confirming, I don't think our pharmacy does pre-authorizations for Medi-Cal clients. I think we just bill Medi-Cal.
Yeah, for the medication they don't. But we get paid for the injection though. That's what I need to do is we're actually charging for the MAs to inject it.
Yeah, we're doing it with a provider visit, and we bill for that.
And then a follow-up in California, Christina asked if Medi-Cal only covers Apretude as a pharmacy benefit rather than a medical benefit.
I wouldn't know. I don't know.
I'm not
That is my
sure.
understanding, but not confirmed.
Sorry. Go for it, Luis. Sorry.
I was saying that that is my understanding, that is a pharmacy benefit, but I'm unable to confirm it at this time.
Ben, do you have something to add to that?
Oh yeah, I was saying the same thing.
Okay. Okay.
And maybe somebody else knows, and I'm wondering, or I'm thinking too, that with with our Medi-Cal folks are on Medi-Cal managed plans, 90-something% of the time, and I believe that Apretude would be a carve out, meaning that you wouldn't need, kind of like HIV meds are, right, or PrEP, where you wouldn't need to get an authorization from the plan, from the from the medical group that they're assigned to, but get the Apretude actually gets directly paid for by Medi-Cal, and then perhaps the injection injection authorization, that probably comes from the medical group. It's my guess.
Okay. So I guess what I'm working through in my mind is that if you are a clinic that has a pharmacy associated with you, it's a pretty quick process to get the product and be able to give the injection. If I'm at a clinic and I see people with Medi-Cal or Medicaid, but I don't have a pharmacy connected with me, how do I get that medication? Does anybody know?
I know about a friend who's doing it at another clinic, but basically you choose a specialty pharmacy that can white bag the medication to the provider's clinic, and the same day that you're going to get it.
Great, thank you, Luis. And now to move outside of California. First, Jillian and then Caroline, could you tell us about the process of getting the medication for your Medicaid patients?
As of present, I have not had any Medicaid patients yet. All my patients are like commercial insurance patients or uninsured, also private insurance or exchange marketplace patient insurance patients.
And could you remind us, does Florida have expanded Medicaid, and has that covered oral PrEP up to now?
Yes, they cover oral PrEP, yes. Some HMO plans do require prior authorization for some weird reason, but it's an easy process.
For our Medicaid patients, it's actually the same process as for private insurance. So what I do is call a specialty pharmacy, and I call in a prescription, and then they will initiate a PA through Cover My Meds if needed, and that'll either go to the Medicaid MCO or to if it's a private insurance, the the prior authorization will come through them. So it's the same process for anyone who's insured for us right now.
Great, thank you. And then going back to a question that Shauna asked, has anyone used this as off-label use with people who inject drugs? I know the FDA approval was only for sexual risk factors. It's Shanna. It sounds like that's a good question. Anybody on the call want to respond to that? So I think if I guess to rephrase it is that because this has been approved for sexual risk, has anybody had an experience with trying to get coverage from either Medicaid or a private insurer for somebody whose indication is injection drug use? Okay, Shanna, it sounds like that's a question for us to follow up on, which we can do. Montika follows up with a Medi-Cal question, verifying that no prior authorization or TAR is required for the medication itself. The pharmacy could bill it immediately as they do for the oral meds. Is that is her understanding of that correct?
Yeah, that's how we go about it. If the patient has Medi-Cal, we'll just walk on over to the pharmacy and we can pick up the medication on the spot. So they charge Medi-Cal. So yeah, that's correct.
And then Peter is asking, and is following up on the question about the indication for injectable PrEP for people who inject drugs. So it sounds like that's something that's of interest for us to follow up on here, and then get the answer out to you when we know more. Irina, am I saying your name right? Asks, when picking up the medication, does the pharmacy charge the patient at that time, or do they bill insurance? Asking specifically about the state of Oregon. I think to begin the answer, I believe that the way that insured people get the medication is through a specialty pharmacy associated with their insurance company, and that process has to be initiated and followed through with the provider or the PrEP navigator. If did I say that correctly? And also, does anybody want to add to that? I wanted to follow up on a couple patients that Christine and I think Caroline mentioned. Christine, you talked about the patient whose prior authorization was declined, and then you met with the insurance company and convinced them to cover it. And I believe, Caroline, you talked about someone who was declined, and I wanted to know what happened with that person. So maybe Christine first.
Well, in terms of what that it was approved and then we were able to give the patient the medication. I guess I don't know what your question is.
Well, I just wanted to follow up and sort of highlight that of one of the challenges of providing this is that for people with insurance, there's been more time needed to be spent.
Correct. Right.
Yeah.
Right. And actually, Ben was doing all the work, and it was fine. We had already sent in various answers to, for a prior auth. You do have to send in certain information. So we'd already done that and gone through. They want to know, do they get HIV tests, et cetera, et cetera. We'd already gone through all of that. And then the final thing was that no, it was rejected, that it was not deemed as necessary. And then, like I said, there really was very little from Ben. Happened to set up an appeal that would where a medical doctor from their group would call me, and then we would discuss it. He did, set it up so that we could appeal it. And then, like I said, as far as failing 3 drugs, et cetera, I mean, there really was nothing there. So I emphasize, the risk that this person is at in getting HIV. And really, I mean, he could take oral PrEP. I mean, oral PrEP is very effective, but I think that I don't think the person on the phone was really thinking of that. They were just thinking, this guy's at risk. I think we need to, let's approve this. I'm not going to deny this.
Caroline?
Yeah, so the patient that I'm talking about had Cigna insurance, private insurance through his employer, and he was denied for injectable PrEP in a standard letter of medical necessity. And then we did an appeal that was also denied. And so now this it's up to the provider who was taking care of him on oral PrEP to do a peer-to-peer. So she has yet to do that, but that's our next step. So he's stable on oral PrEP for now. And so that's kind of something that we take into our consideration too, with how aggressively we move forward with the paperwork and the peer-to-peer and these steps. If someone's stable on oral PrEP, then they have a little bit more time than if they're new and maybe they're only open to injectable. So we know he's safe for now.
So a follow-up to that, to everybody who's on our call today, has anybody who's doing injectable PrEP had an instance where like in Caroline's patient's case, they still have not been able to start injectable PrEP because of insurance denial? And then I guess another part to that question, for people who have started injectable PrEP, have there been instances of subsequent injections being denied? Have people had to go back and forth between injectable and oral in order to stay protected?
Yeah, I'm not aware of any. Ben keeps a closer eye on that, but I'm not aware of any.
Yeah, we have had challenges with like the pharmacy, because like a lot of our patients have to the CVS pharmacy, the pharmacies, and that's where I come like with those big like challenges where like when like it's covered 1 month, the next month say, oh, it's not covered. I'm like, well, you paid for it last month, and it's like they don't know how to bill. It's a refill. It was billed through pharmacy last time, to medical last time. So I'm always having that fight with them like every 2 months for the most part. And usually that's where I go into Vive Connect and I talk to my person, my FRM, and like, hey, they paid for it last month. Why is not paying for this month? Like, what do I do? And some way, somehow they call the pharmacy and it gets approved. So I get that almost every other month, and then like, it's almost time for the injection and I don't have medication, so I have to like figure out how I'm gonna get the injection to them, before they miss that window. So yeah.
Has anybody had any issues with insurance companies covering multiple RNA tests? In other words, every 2 months putting through for reimbursement for an RNA test?
I can say that we, on the billing side, to my knowledge, we haven't had trouble with those viral load tests.
Okay. And does Chris Hall, my colleague at CAPTC, could you just walk us through or remind us about the requirement for the RNA test, and if that is in fact a requirement or just a recommendation?
Well, I mean, the guidelines that were updated by CDC in December 2021 call out the need to use the most sensitive, tests that we have to, in an effort to ensure that we are not missing folks who became positive, typically right before, drug was begun, in the interim between, say, initially working with your patient and then getting the drug. And that was, because of the HPT and 083, finding that, there could be delayed production of antibodies in these cases. So that's why CDC has recommended the HIV RNA as that screening test every, at the screening intervals of every 8 weeks. So, I mean, is it required? I mean, it's recommended, and guidelines are guidelines. But I think for the most part, that's what people are doing. I haven't heard of issues either with reimbursements. That's good to hear.
I know that before injectable PrEP, some insurers were balking at covering multiple HIV tests and multiple STI tests during the year for their people on oral PrEP. I think some of those problems were corrected, but that has been a concern with injectable PrEP, especially for clinics or for sites who don't routinely do RNA or viral load testing, is trying to implement that as part of the protocol for delivering this.
Yeah, oddly, the only, as far as getting multiple STD screenings, the only time we have trouble with that with PEP or are Medicare patients. Medicare doesn't want to pay for multiple screenings for some reason. So, but we still make it work.
I think Caroline and Jillian, you both talked a little bit about your retention or your reminder strategies. I'd like to follow up and hear from each of you again on how you are making sure that your patients are making it in a timely way to their appointments. Luis, do you want to go first?
Could you repeat your question one more time?
I just wanted you to share with us how your retention plan works for your pilot program. In other words, the appointment reminders. Have you had to bug people who were no-shows, et cetera?
Yeah, so basically now, because I handle all the scheduling, I have my own spreadsheet where all the clients are with all the dates and the target dates. And I have reminders for myself to let the provider know to drop in the script to the pharmacy, make sure we have it in stock for the day the client comes in. I schedule the client and then I call them a couple days before their appointment to remind them of their appointment. And if I can't leave a voice message or if they don't answer, I send a text message, and they all have my direct phone line. So I am not sure how that's going to work out when I step back, because I can't possibly be doing this for 100 people, or I said 30, right? It's just too much. So at some point, I will have to reduce the sort of the hand-holding level that I'm doing right now, and just do very similar strategies that we apply for oral PrEP. And like I mentioned, creating a report with HIS that tells me which clients are not scheduled and based on prescription date should be coming in within X number of days. And that X is the variable that I play with, that has to do with how soon I can get a client in. So say I can normally get a client safely within 7 business days. So that's the variable in my report. It gives me a list of chart numbers. I upload those chart numbers into a different piece of software that sends emails with a template that has been predefined and created by me to those clients. That is what I do for oral PrEP, sort of as the most sort of automated, broader scale. And then, there's specific intervention for clients. But that's kind of as we can see, this, in terms of human resources, it takes a lot, right? Because of the timelines being a little more strict, I think I'm happy to see that what I thought was personal anxiety is actually more generalized, about making sure the clients come in within the windows that they need to come in, and avoid as much as we can having them go back to the oral version, even though that's not an issue. And maybe that's kind of what we need to normalize, that some of these clients will be sort of kind of in a seasonal way moving between the injectable and the oral, and just having a solid workflow that can sort of accommodate those clients.
Thank you. Ben?
Yeah, I echo that. I think the case management part is really important, but it can also become overwhelming just handling, a handful of patients. But I think it really does give an opportunity for us to maximize technology. I really like Lisa's approach to it. We use this platform, Frisia, that sends out automated messages as well. And I think that can be really helpful in terms of sending out reminders to patients, but also just doing diligently following up and making those phone calls, and making sure that those appointments are scheduled when they're leaving the clinic, that day when they come in for their injection, making sure that their appointment is scheduled before they leave the clinic is some of the things that we do here, but it definitely requires a more involved sort of approach compared to oral PrEP. But so definitely using technology and making sure that their appointments are scheduled before they leave the clinic are some of the things that we're doing now.
Great. Yeah. Jillian, do you want to just walk us through your retention reminder procedures for your injectable PrEP patients?
Yes. At first we're having issues with that. So to make it a little bit more consistent, the patient before they start their first injection, they sign an agreement form that kind of like states they have to be very compliant with the window visit, and that if they miss it, they have to go back to oral PrEP and they want to extend the injection. So they sign a form, a contract essentially. So that kind of like keeps them in line to like stay on their appointments. I also had a calendar, like I create like a math calendar, like based on like when they came, like their window visit. And I work very closely with our navigators to schedule those appointments with the patient. So if they're about to miss, I send like a message, hey, make sure they come before that date. And so I work with our outreach coordinators just to ensure they are like, staying on schedule and even coming earlier if possible. And actually we have someone like who is very responsible and kind of like calculated out like their visits, and they're gonna be out of the country. So they scheduled their first, and their first injection so that they would not miss, like their appointment. So we have some people who are very, compliant, like, and very responsible, and some we have to kind of like chase, and like, please come, like, at your appointment. But with our outreach coordinator team, we have texting options, reminders, like every the week before to ensure they'll stay on their with their appointments.
Thank you. Caroline, tell us what you're doing.
So I am reminding people via text. I'm making their appointment in the clinic with me. And like I said before, these are people who self-selected, who are interested and motivated in being on injectable PrEP. So I haven't had a problem with them not showing up to their appointments. Also, just to note about our panel, over 75% of the people on PrEP with us have been on PrEP for more than 8 months. So, and some of those people for up to 4 years. So we have a pretty steady panel. So our challenge is more on uptake and persistence for people who just start, but not with this group, since this group was kind of established patients already. I just wanted to ask the people who are using automated reminder services, if you could put them in the chat. It's something I would want to look into. I know, Ben, you mentioned Frisia, but Luis, I wasn't sure what you were using.
We use Frisia too.
Okay. Thank you.
So I wanted to bring up another question from Lantika. What's the general gestalt, she asks, on whether Apritude has brought in new PrEP users or patients who had challenges with adherence on oral PrEP?
What I've noticed is, generally speaking, it is people who have changed from oral PrEP to injections. But I have had 2 patients who maybe came for STI testing or something in the past year or 2. And when I talk to them about it's a pill you take every day, they've said, oh, no, I can't take pills. I'm not going to take pills. And then If it was, if I knew that the injection was coming up, the end of last year, I was telling them, okay, there is going to be an injection. And they've said, if there's an injection, I'll do that, but I know that I'm going to miss pills. So I would say 2 people have said that.
I want to acknowledge our time. Our panelists are available to stay after the hour to continue our discussions and our questions, but I did want to just make a couple of announcements. Liz, could you put up the second slide, please? So we didn't get a chance to get into equity very much. Maybe we'll do that for those of you who can stick around. This is kind of an in-your-face slide, and I admit that readily. I think all of us have been hearing about PrEP equity and sexual health equity for a while now. And I feel like the question is being asked very well, and I'm not really always hearing the practical or the logistical answers. And so when it comes to us providing injectable PrEP to people, are we learning from the lessons from oral PrEP for those people for whom it has not been easy to reach for PrEP and who would benefit from it? I also want to add that I know of several organizations, several training centers who are going to start injectable PrEP series soon. And so we're going to move our series to more of an as-needed basis rather than duplicate the content from some of these other seminars. And I'll be sure that you all are notified about these additional injectable PrEP seminars in the future. So feel free to stick around. We'll follow up with a couple of points here, and you can continue to add your questions to chat for a few minutes. Liz, you can stop sharing. So I think to follow up on Montika's question and on Christine's response about people who have not wanted to take oral PrEP agreeing to take injectable PrEP. Who else has something to add to that?
I just want to say that I know that the commercial has aired, so more people are becoming, like the commercial that was made by Vive to promote Apretude has been is out now, so more people will become aware of Apretude. We actually had one new patient call in last week who started Truvada but did not tolerate it and knows about Apretude and wants to start on Apretude and was on Truvada for 10 days. And just wants to jump straight into Apretude. So the messaging is definitely getting out there. And I think, like, just to echo what Christine said, it's more of a convenience for people to come in every 2 months for an injection rather than taking a pill every day. So yeah.
Anybody else want to add to that subject of people who we were not reaching with oral PrEP or who declined oral PrEP? And if we're doing a better job getting them injectable PrEP?
I think because of the nature of the fact that it's a pilot, it's mostly the clients are being referred by providers when they come in for their PrEP follow-up. So mostly we're transitioning clients from oral to injectable. I think at some point we will, sort of make it visible for our larger community that this is available to them. And I can imagine then a drastic change of who is requesting those services. No new clients to PrEP. No one has started PrEP through the injectable. I think that can change once we roll it out. I do have a couple of sex workers who prefer to be on the injectable. They like the idea of getting tested for STIs more frequently. So instead of 3 months, 2 months, because of the nature of their work. And they feel safer because the protection against HIV doesn't rely on them remembering or forgetting to take a pill, and therefore they just feel more safety. I thought that totally made sense to me.
Thank you, Luis. I want to pivot back to the equity topic. Caroline, I know you mentioned in your presentation that that was something that was on your mind in your program. I want to invite you to add anything that you'd like to that, and then also for everyone to sort of talk about how they're thinking about equity in injectable PrEP.
Yeah, thanks for kind of highlighting that. Excuse me. So we are doing a couple things to make sure that education about injectable PrEP is distributed fairly. And one of those things is we've started an audit and feedback process that looks at conversations. We do individual chart reviews to look at conversations that providers are having or not having about PrEP with eligible patients. So, for instance, if someone comes in and has a diagnosis of syphilis, um, that really puts them in the pool of being eligible for PrEP, being prioritized, should be prioritized for PrEP, and so our audit and feedback process looks at, like, did someone come in and was that conversation a missed opportunity? And then we actually talk to providers on an individual basis to make sure that they realize, their gaps and their blind, where they're not seeing things, not seeing patterns. And one pattern that we've uncovered is that older cis Black men who, even if they have indications like they've been, they've paid for sex recently, or they have had a recent history of gonorrhea or something like that, they're not having conversations as frequently about PrEP. So, for injectable PrEP in particular, it's just making sure that providers are talking about PrEP and talking about all three options that we have right now. So that's one way that we're targeting. Another thing that I really want to start pushing is our social media presence. We have the ability to create content, and we have accounts on Twitter and I think Instagram, but it's sort of because of short staffing has been, laid fallow. We haven't done anything with that. And so I think that that's also a great kind of equalizer, a way to make sure that the information is out there, and then, put the onus on the people to call us and get in touch with us. So those are two approaches we're having to make sure that information gets to everyone.
Montika, I'm going to put you on the spot, and you can get mad at me later. That's fine. I know that when you and I emailed back and forth about starting the injectable PrEP program at San Francisco City Clinic, that you said that one of your priorities was equity. Do you feel comfortable sharing some of the discussions you're having in designing your program and some of the thoughts you're having about equity? And if you don't feel comfortable, please say, I don't feel comfortable.
Can you hear me?
Yes.
Hi, I feel comfortable, but I actually have to go to another meeting.
Oh.
But we have not started injections here yet, so I'm learning so much from this presentation, these presentations, and thank you everyone for sharing.
Okay, thank you. So continuing, who else has thoughts about injectable PrEP equity? Feel free to come off mic.
I would just say that we have certainly a lot of opportunities. Like everyone, a lot of things got put on pause during COVID. So a lot of our normal outreach activities that we would normally do, we haven't been able to do. Also, to echo, I think Caroline was saying that with them, we also have social media opportunities. I think a couple of things that were, since Apertude is still fairly new, and we were trying to get our sea legs, we didn't want to promote it too much. But I think we're at a place now where we can do that. And but the challenge though is too that we're not an agency that has a lot of extra resources in terms of really keeping the social media stuff up to everyone has 5 other jobs that they do. So that social media piece is definitely something we can hopefully exploit more. And then also we can utilizing technology, we can we can send messages to all PrEP patients, for example, or even some of our other folks who are not our patients to let people know, do more of kind of a, I guess you'd say, a direct marketing kind of approach, or to make sure that all of our patients or people we touch in our agency know about know about injectable PrEP, and know this is just like at the beginning of oral PrEP, know that they can get it. A lot of people a lot of folks made assumptions that I don't have insurance, or I don't have this or that, and I don't have money for a copay, so that means I can't get it. So I think making sure that the community knows, all parts of the community know, that it's not only available, but that that everyone, if you come, we can, no matter what your insurance situation or financial situation, we can get you on it no matter what, and so that helps.
I know that, I'll put on my bossy hat for, the things in its ability to take the medication, and therefore didn't offer it to them. And I hope that we have learned from that to not make assumptions about our patients and their ability and their desire to be on injectable PrEP, and to understand their other vulnerabilities and the other complications they have in their life, because those are, in my mind, are the exact people that we have been trying to reach with PrEP.
I totally agree. Yeah,
that's my soapbox.
That's a good one.
So I'll give another minute or so if anybody else has follow-up comments or questions.
Back to your I guess the equity, at least for our clinic, our patients do not come on a regular basis. And that's the problem for us. Like, they come whenever they want. And that's kind of like where we're trying to assess, are they really appropriate for the injection? Because they have to really like stick to that window. Like, they come like every 6 months, because with our program they have to come every 3 months is how our program works, and they come when they want. Like, we really have to kind of like get them committed to like staying on a strict schedule to be on the injectable. We will, I mean, like, we're willing to offer it to them. So that's why I guess the contract comes in. It's like, okay, I signed something that I need to come, so I'm really gonna stick to it. And so I think that will eventually increase our equity and our access for our patients who really wanted to like get on it. So
yeah, I mean, that it goes back to that hierarchy of needs that we used to talk about a lot 10 or 20 years ago, that how many of the patients that we see do not have the ability to plan 2 months in advance? How many of the people wake up and they don't even necessarily know how their day is going to go for different reasons? So it sounds like that's one of the challenges that you are confronting, Jillian.
yes. Yes.
Anyone else with something to ask or add?
I wanted to ask Ben about the PN role and how responsibilities are being shared and communicated between team members.
Oh, like PN as in PrEP navigator?
Yeah, sorry.
Oh, that's okay. Well, Christine and I work very closely together. She's our sole provider who sees all of our PrEP and PEP patients. So it's really a collaboration between the two of us. Anytime a patient expresses interest in starting Aptitude, I will submit a ViiV enrollment form. So I can get an explanation of benefits or have them enrolled into the patient assistance program that day. So it's kind of like she meets with the patients, has a conversation, introduces Aptitude. If they express interest, she'll relay that to me, and then I will get that process started, the benefits navigation and PrEP navigation portion started. So it works that it's only really the two of us who are working with our PrEP patients. So it helps in that way that, you know, the messaging isn't getting lost anywhere. It's pretty clear. And we keep each other informed. So yeah, I don't know if that helps or if that answered your question.
Yeah. Do you personally meet with patients, or do you do anything for coordinating reminders or anything like that?
Yeah, so part of my role, and I think most PrEP navigators do meet with the patients, whether it be, you know, adherence counseling or enrollment into any type of benefits programs. So we're definitely, I'm definitely meeting with them. I'm also explaining to them what I'm doing. So if they are interested in Aptitude, I let them know what the process entails. So submitting that enrollment form, letting them know the turnaround time for that, continuously keeping them updated with any messages that I receive, either from ViiV themselves or their insurance companies. So I always want to make sure that they're aware of how long it'll take, especially if it's private insurance. So always definitely communicating with the patients. So yeah.
Yeah, thank you.
Okay, Nicholas has another question, which I want to get to, but I also want to acknowledge we've been now 14 minutes after the hour. I'm popping my email address once again into the chat. For those of you who have follow-up questions, challenges, ideas for further discussion, feel free to email me. And then Jillian, Nicholas is asking what about the response from your patients about signing the agreement. He says, we're by the border and PrEP appointment attendance is a big challenge for us as well.
So thus far, so some of the patients realize it's not for them because they go like from place to place. They're not like stable. So, but it's it's probably like 1 or 2 patients, but most of the patients once they sign it, they agree, and they've been so far compliant on it. Because right now we are on, our first injection started in April, and now we are on we have some on number 4, and they've all been very, very compliant with so it works for us at least. Because there's it's kind of like an understanding between us and the patient.
I'm going to make an assumption here about Nicholas's question also, and ask about all of you whether you have materials that you're presenting to the patients in Spanish and in English, or in more than one language than English.
So we have it in Spanish and English because our clinic is more Spanish and English. So we have both. And if he wants, I'm willing to share with him. Just send me his email address and I can share with him the agreement.
That's great. You've sent me the English version, which we're getting up on our PrEP injectable PrEP website that I put up earlier. So if you want to send me the Spanish version too, we can put that up.
Okay, perfect. I will.
Anything to add?
Yeah, actually, I did have a patient come in the other day, and we hadn't seen him in, I don't know, 2 or 3 months following his first injection. So basically, I was going to go in there and tell him, this isn't a good thing for you. And I was going to focus on the fact that, you've got a little bit of a medication inside you, and should you become HIV positive at this point, you're likely to get some sort of resistance. As it turns out, he's actually a new PrEP patient too, but he said he had worked it out with his boss, that he has Mondays off, he'd be able to make the appointments. But basically, I was going to be very firm with him that, you have to come on your scheduled visits because of the fact that, you could get resistance to HIV. So a matter of educating him on why it's important that he do that.
And it sounds like that was convincing to him, or so far it's been convincing.
Correct. And unfortunately, like I said, he probably took PrEP for maybe 2 months before he decided, no, you know what? Now that I think about it, he came in with his partner and he wanted to go straight on to Apretude. So he might have had 1 or 2 injections, but then we just didn't see him, wasn't answering his phone and the whole bit. And then he did come back. But yeah, if he had not told me of some sort of plan that he had, which would change the situation, in his case, he said, I sat down with my boss and I have every Monday off so that I can make these appointments. Yeah, I would have, talked to him about pills because, pills are a little bit more flexible in terms of I can send a pill, I can send a month out, with an agreement that you're going to get an HIV test and that sort of thing. But, I can't really send the injection out.
Yeah, I mean, you're highlighting, I think, one of the challenges that we've been concerned about with injectable PrEP. I know with oral PrEP, a lot of times people might miss a visit, but for whatever reason, they have a few pills more in their bottle than we thought they had, and somehow it all works out for them.
Mhm.
Okay, thank you all very much for sticking around for this conversation, and have a wonderful rest of your day and be in touch.
Okay, thank you.
Thank you.
Thank you.
Thanks.